Hello, everyone. Thank you for joining us today in the webinar. Um, my topic today is about parenting. We've all heard that parenting is stressful and rewarding. Um, and I wanted to take a look at this from the lens of substance use disorders and how it changes the parenting brain. I also wanted to put it out there that a lot of the research is done in mothers, because part of it is they're easier to access and more and easier to compare. But I just wanted all of us to have an open mind when we think about parenting. A little bit about myself. I'm a child and adolescent psychiatrist. I'm at Dayton Children's Hospital. I'm also an associate professor at Wright State University since the last 1 year. I am a fellow with 0 to 3. And before I moved to Dayton, I was an assistant professor at Marshall University in Huntington. And I also worked at Prestera Center for about 6 years prior to that. I have also been a steering committee member for Healthy Connections Coalition. I do not have any conflicts of interest to disclose. My objectives today are to review normal brain development, to learn how substance use changes the adult brain, and to compare brain changes in parents without substance use disorders to parents with substance use disorders. Well, I'm really excited and honored to be invited to speak today for Healthy Connections webinar. Um, and just to give you a little bit of background, you know, when I was at Marshall University during a slow week in December, I had a conversation at a water cooler with a therapist. His name is Louis, and he was therapist for the pregnant women in the OB clinic with substance use disorders. I was a child psychiatrist seeing children as young as 4 or 5 years old with severe behavior problems who had a history of either exposure to substance at birth or whose parents were struggling with substance use. And we were just started talking about how much has happened in those 4 or 5 years that we don't know about, and how there could have been so much that we could have done to help them, knowing that these women were at risk. Um, and then a few years later, the children were coming up with significant difficulties and emotional difficulties. So before I knew it, Louis was out getting people together, connecting people across the spectrum of services from pregnancy, getting us all to know each other and working out ways to make sure the pregnant women and their families do not fall through the cracks. And this is still a work in progress. And, but I wanted to focus on the vision for healthy connections. Every infant or toddler being raised in a family struggling with substance use disorder will have the opportunity to build a healthy brain through healthy relationships with their caregiver. And each of their family members will be supported in recovery and parenting. And we wanted to focus on family as a unit because we know that families come in all shapes and sizes, and we see kids being raised by adoptive families, grandparents, step grandparents, anyone who can take care of the child, and anybody in the household could be struggling with substance use. um, but we want to be able to give those children the opportunity to build a healthy brain through healthy relationships. The most interesting and exciting thing about this conference to me is that we have an audience today that includes both those who work with adults as well as children. That's usually rare because in healthcare for adults is very distinct and separate from healthcare for children, more specifically babies and toddlers. And the two generally don't intersect, coordinate, or collaborate. But if you are someone working with adults, then I would encourage you to try to think of them not just as adults with a substance use problem, but also as parents or caregivers to a young child. No matter what discipline you may be working in, think about how it might be impacting if there was a young child in the house. If you're someone that works with children, then I would encourage you to conceptualize this child's difficulties as not just being their difficulty, but also including the adults in the world in their world. Only by doing so we can help break down these barriers that exist between these two worlds and help support the family as a whole. So let's talk about normal brain development. And don't worry, I'm not going to go into a lot of details, but I just wanted to focus on a few key points, right? Um, the good news is that human brains are built over several years, which means, when you're talking about building a highly efficient top class machine, then it's great to be able to take the time to build it. So it's in good condition when it's used. The bad news is that human brains are built over several years, which means there's a lot that can happen over these years that has the potential to push this building off track, right? So that means there's a lot within the environment that can change how these brains are built. We also know that human brains have neural circuits that get stronger when they're used more often and get weaker or fade away when they're not used as often. So, this is important because when children, infants, and toddlers have the opportunity to use a variety of different, uh, ways or as ways to solve problems, then they are able to think more flexibly. Whereas if a child or an infant learns that the only way to get their needs met is by screaming or yelling, then that's the go-to mechanism. Other more appropriate ways of getting their needs met might not even be considered, right? So, so these, so the circuits that are reinforced get stronger, and those that are not used get weaker and fade away. The other unique thing about building the brain, that's kind of different than building a computer, is that these circuits are experience expectant and experience dependent. What that means is that these neural circuits are really primed for experience. When they have a certain experience, so as the brain is being built, the architecture or the so-called hardware of the brain is being built. Um, it also incorporates the experiences in the environment. So it's downloading these templates from around it as to how the world works, and that's incorporated into the hardware. So these experiences can how change the neural circuitry and change the architecture of the brain. And it's experience dependent in the sense that without certain experiences, certain parts of the brain lose that ability to make those connections. And a lot of times there is this window of opportunity, this critical period in development. And during that time, if they don't have those experiences, then it's harder to modify the brain later on. So let's talk about the role of healthy relationships in building a healthy brain. What are some of your thoughts when you see these faces? These look like really innocent faces, but they're living beings. They're scanning the environment, looking to trap an adult into picking him up, promising to help him. And this adult caregiver now helps to regulate, to helps this baby to survive and take care of the baby, right? So there is research that says that there are inherent properties in infants' faces that draw the attention of adults and promote caregiving behavior. So an adult, it basically creates a feeling in the adult that they want to take care of this baby. and by doing so, helps the baby survive. The other job that this attachment does is that it forms an early template for emotional regulation. As an infant, bodily needs like hunger or being wet or soiled, these can all trigger intense emotional feelings of distress. And, the baby is seeking attention so that they can come back to their baseline. They can feel comfortable again. And what the adult does the adult in their environment does by responding to those needs is not just help take care of their physical needs, but also help kind of calm down some of that intense emotionality and distress. And when they receive such multiple predictable interactions with a stable caregiver over time, the baby learns effective ways of seeking help. These are some of the postulates of Bowlby's theory of attachment. He also talks about how, you know, what is really meant by love. There is the need for the baby to know that they are the apple of the eye for an adult caregiver, and that this is unconditional love. This is important because for the toddler to know that they are valued, they are worthy of love and attention. And when self esteem is positive, basic needs are met, um, then they can move on to the next task of learning, right? So when they feel confident about themselves, they're able to separate and explore the world. When something scary happens in their world, like, say, tumbling tower of blocks comes crashing down, that's scary, they can run back to their secure base or caregiver. And until they feel safe, until they get the signal that it's okay to venture out again and explore some more. This learning early on in life is important because it helps them build the tools that they need to be secure, productive adults. And these are life skills, right? Being able to collaborate with others, being able to get their needs met appropriately, being able to express the needs appropriately. So this is a child then who can have a secure attachment. And this forms the template now for future relationships. So based on their relationships with their adult caregivers, they are then able to anticipate what the world is going to be like. And they go in with a more positive expectation, resulting in more positive relationships. So, in short, the importance of this attachment relationship is not just emotional, but also biological. And a caregiver who is attuned to the infant's cues responds appropriately to their cues without being overly intrusive or overly punitive, um, and then fixes the situation for the infant. Over time, the infant then internalizes methods of calming distressing feelings in a healthy way. And this is how, healthy relationships can are building blocks for building a healthy brain. At the time of birth, many of our organs are functioning the way they're supposed to be, but the brain is the one organ that essentially needs another brain for development to its full potential. So, when we think about a child's brain, we also must think about who is around that child and how they're influencing the development of the child. So now that we know a little bit about normal and healthy brains, and we went through the attachment theory put forth by John Bowlby, let's talk a little bit about substance use and addiction and how that changes the brain. Um, so One way to frame addiction is as a disorder of attachment. We talked about how attachment helps us feel calmer. Um, when that relationship is not available, it may lead for the child to have an alienated sense of self, um, or they're unable to manage fearful and anxious mental states about themselves or others, and unable to regulate emotions, go back to baseline level of comfort. And so, as an alternative to relationships, substances kind of fulfill that role of feeling good or feeling calm or feeling in control of your negative emotional states. This slide basically talks about how substances can change our baseline sense of what's normal, right? So there's this line here, which would be considered baseline. Um, when a substance is ingested or enters the body, there is a first peak of feeling good and feeling high. And what that does is, it's kind of immediate, and it um, makes one feel really good. But when the body is in that elevated state, other processes get activated and tries to bring the body down. And these compensatory processes can take the person further down into a negative feeling. And then it takes a while to kind of get back into feeling more like yourself. So this is kind of like what may happen with one ingestion. And a lot of times, many people do use substances randomly, infrequently, and they do not get addicted. And they are able to, use it, feel good, but not become dependent on it. Um, and this may be due to individual differences or genetic differences. Now, when substance use becomes more repetitive, there is a dysregulation of the reward system. And with repeated use, the peak of feeling good is further lowered. And when substances are used more frequently, even before the mental state or the affective state returns to baseline, um, it's it's it makes the feeling of high not as effective as it was the first time that they used it. So allostasis is basically process of achieving stability through physiological or behavioral change. So the body or the brain is looking for some stability, but there is continuous reevaluation of need. So, what may have been a one time having a good time at the bar, then with more frequent use, the need is reevaluated, and that may change to, I need to go to the bar. I have to, I have to go. I want to go, and that becomes more, that changes what your baseline is. So the feeling of being at a stable place, at a good place, goes down, and that is the allostatic state. There is a new equilibrium state of chronic deviation of the regulatory system from its normal operating level, which is up there, to more of a pathological operating level. And so the set point has changed. And then this over time. So the long-term cost of allostasis that accumulates over time and reflects the accumulation of damage is called as allostatic load. Now this was described by George Koob, and basically he was trying to explain how, some people may use substances and never look back at it again, but then some situations where there is a transition to dependence, and at some point it switches to addiction, where you're just trying to avoid the bad feeling. So in the beginning there is more activation of the dopaminergic systems, which is the reward system. And then as the use becomes more frequent, there more parts of the brain are involved, and the stress system gets pulled into this. All right. So when there are stressors in the environment, um, it leads to, again, thinking about, uh, the good time that was had and trying to recreate that by using the substances. And initially, the reward experience is higher, but then with repeated use, it tends to go down. So addiction is also defined as a negative affective state that includes dysphoria, irritability, and anxiety during abstinence from a more continuous or closely spaced pattern of administration of drug, particularly as the severity of symptoms increases. And this state appears to reflect a decrease in baseline reward mechanisms and an increase in drug intake to compensate for the shift in the reward baseline. So part of it, the reason again is that, it's not just the dopaminergic or the motivational system that are involved, but also the stress systems gets involved. And this is the point of vulnerability where it can spiral into further dysregulation. Then there's a state of protracted abstinence, which can be also described as a state of residual reward dysregulation. So after the acute withdrawal period is over, the brain, even after several years of abstinence, we know clinically that people can be still remain at high risk for a relapse, and that's because of this changed set point. um, Increase in glucocorticoids, CRF. These are hormones that can lead to negative affective states that last long after the physical symptoms have subsided. So now we have an already compromised reward circuit that is depleted or dysfunctional with the opioids and the dopamine systems. And then in addition, there is a negative affective states, and there is dysregulation of the stress axis. So all of these kind of make each other worse. And in terms of the addict, the reward system has to work harder and harder just to stay in the same place. So basically, stability is purchased at the cost of increased resources and a decreased margin of error or reserve. Majority of relapses occur during states of stress or situations with high drug queue or drug availability. So there is this subtle state of residual abstinence, even after acute withdrawal. So in situations where there's environmental stressors or cues or drug associated memories, that can put an individual at higher risk for relapse. So we saw how brains change related to substance use. How does that impact parenting, the parts of the brain that are involved in parenting? We know that parenting is stressful as well as rewarding, and how are these kind of changes interacting with each other? So I wanted to bring to attention this study that's been done back in 2008, a very interesting study. This was a functional MRI done. They took 28 first-time mothers, and they were shown images that they had never seen before of their own baby that was between 5 to 10 months old, and a matched unknown baby. So they took several different pictures and matched them, and then they picked out pictures of their own baby with a happy face, own baby with a neutral face, and an own baby with a sad face, and then the matching sets of unknown babies. And what they did was they basically presented it to the mother in random orders for 2 seconds, with a break of about 2 to 6 seconds in between. What do you think happened? When, so they were monitoring the fMRI. When first time mothers see their own infant's happy face, what the researchers saw on the fMRI was like a Christmas tree lighting up. An extensive brain network seemed to be activated, and the dopaminergic reward related brain regions are specifically activated in response to happy but not sad or neutral faces of their own infant. So that was interesting in that it was one of the first studies that showed, um, that sort of delineated this maternal feelings towards their babies in a, in an imaging study. 9 years later, Strathern conducted another study, this time with mothers in SUD treatment, but again, very similar protocol. 36 mothers receiving inpatient treatment for substance use disorders of different kinds of substances, and they were scanned at 6 months postpartum. While uh, they saw happy and sad images of their own infant compared with matched unknown infant. Now, when they were viewing happy face images of their own infant, mothers with addiction showed a striking pattern of decreased activation in dopamine and oxytocin innervated brain regions. These were regions in which increased activation was previously observed in the first time mothers without addiction. This was one of the first testings to show that mothers with addiction had reduced activation in key reward regions of the brain in response to their own infant's cues. This indicated that the reward salience, or how important or how much priority they gave to their own infant's cues, was kind of reduced in mothers with addictions. And that this pattern was most pronounced in the case of their own infants. So they were more likely to look at their own baby's happy face and go, so what? And that's probably because of how addiction changes the set point, right? So it requires more to get excited, to get happy, to feel good. And it may also be because some mothers may have had altered brain reward sensitivities over the course of their own upbringing. And this is kind of important because we all know that early on in motherhood is very stressful and um, exhausting, but the the reward feeling that comes from infant cues often help to sustain that mother's attention and responsiveness to their infant during a critical development period. And so, when this kind of circuitry goes awry, mothers may be compromised in their abilities to take care of their infants. The other system that gets activated is the stress axis. And we really need the stress system to be agile and nimble. We don't want stress hormones to be at high levels all the time. It's sort of like we want it to jump into action when there is a stressful situation. And when there is enough cortisol to keep the situation under control, the brain must shut off the cascade. So, and that's pretty much how it works in a normal situation. Now, in addiction, the stress axis is altered. It reduces stress tolerance dramatically, and it can either shut down the maternal response or over control. And simple infant cues can be perceived as stressful. So a person with normal stress axis, if the baby is crying, they may be like, oh, my baby needs me, and want to help the baby and feel good about helping the baby stop crying. But when the stress axis is dysregulated, simple cues like crying can also be perceived as stressful. Taking a new baby home requires a lot of adaptation and changes. And when stress tolerance is lowered, successful adaptation to the new situation can be maybe not as smooth as expected. The other hormone that's involved in parenting is oxytocin. It is known as the pro social hormone. And it's the hormone that, when it's released, it sets into motion the process of labor and delivery, and also release of breast milk. So it's really at high levels during that early bonding time. Um, the brain area that's on the base of the brain, right above your the eyes on the plate, is the orbitofrontal cortex, and that's the area that activated in relation to feelings of maternal love and attachment. And then there are other areas that process um, relationship aspects of things like uh, caress like touch between individuals. And this kind of um, predicts the affiliative behavior between the mother and the infant. Now, in addiction, the reward feeling of uh, the the reward sensation of things like social relationships, social affiliation, are just not as salient, um, because this whole system has kind of been hijacked. And this has implications not just for parenting, but also relationships in general. Um, their own personal experiences as a child can predispose them to difficulty in recognizing and understanding emotions. And as a result, not being able to tolerate their own sense of affective states, the mother may face a lot of distress. So, we see how this is a cycle with changes in the changes in the brain caused by substances dull the reward pathway, dysregulate the system, decrease oxytocin. And they're just not individual, they also interact with each other. So the reward pathway dulling interacts with, makes the stress system dysregulation worse, and each makes the other kind of pulls it further down. And the ultimate result is that there's less sensitivity towards the rewarding value of infant cues, leading to a high stress situation and drug cravings and possibly drug use and further relapse. And oftentimes, the question in our mind comes up as to, how could she do that? How could she leave this beautiful newborn baby and go for drugs? And unfortunately, there is this change in the set point in the brain that makes certain things just not as rewarding. The result of some of the drug use is that there could be tendency to ignore important emotional aspects of relationship with the child. Um, Negative affectivity, such as feelings of anger, ambivalence, and incoherent attitudes in response to their child. They could be more rigid or authoritarian, using physical punishment or threatening to discipline the child. Alternatively, they may be quite passive, permissive, not really supervise or control or provide limits and boundaries to their child. There's also a risk of role reversal. The child may feel a need to satisfy the adult's expectations. The parent may be unable to fully perform parental functions. And then there may be limited knowledge of adequate care practices. And so we have now these children who are at risk for adverse childhood experiences because of their parental substance use. And we know from the research in ACEs that with multiple adverse childhood experiences, it increases the risk for substance use in adulthood. So, attachment, is again not just based on what the mom does, but also what the baby might do or the child might do. And in utero exposure to drugs like heroin and cocaine can make the newborn more irritable, making it harder to be soothed and bond with the caregiver. Things like NICU stays, medication management, trying to give a newborn baby a medication regimen, protracted medical problems. These are all additional sources of stress, as these infants need more medical appointments, additional care. Difficult babies offer fewer reward opportunities, perpetuating feelings of guilt, inadequacy, and shame in the new mother. And the neglectful behaviors could be the results of actions directly under the influence of substances or due to irritable moods and negative emotions. We also have to consider the mother's own experiences with her early caregivers, and the suboptimal environmental responsiveness, nurturing, protection, and containment leading to insecure attachment in the mother also results in these biological deficits. And in general, a substance use can interfere with the mother's ability to guarantee herself as a constant and available presence, both physically and psychologically. So, what do we do now? Is everything lost? Are we too late? Or can nothing be done? And I just didn't want to leave you all with a sense of despair. And so I also wanted to focus on some things that can be fixed. And, not going into detail of this, but uh, st- we talked about the stress circuitry, reward circuitry, and the parental circuitry. And see, there's a lot of overlap. But then the heartening thing is that there's also a lot of areas that do not overlap. So there are still certain domains in the brain that are not entirely co opted into the drug addiction system. There is empirical evidence that drug addiction does not fully or always compromise parenting. And there is a possibility to preserve a healthy caregiving relationships despite the psychopathology. Addiction and parenting do have partially independent domains, and each one can be attributable to a host of factors. The postpartum period is specifically a time of vulnerability to stress, and therapeutic approaches that target stress regulation can be very helpful during this time. Maternal behavior can be altered by numerous other factors, such as maternal psychiatric symptomatology. Um, so, treating maternal depression, maternal anxiety, or psychosis, getting those disorders under control can be helpful in modifying maternal behavior. High levels of environmental stress, such as poverty, unemployment, homelessness, domestic violence, which commonly coexist with addiction. You know, if there's if those can be changed or impacted, um, they're not necessarily the cause of addiction, or they're not directly impacting the addiction, but they can impact the caregiving relationship. The other key to remember is that the presence of a child constitutes an additional value to treatment, and it promotes retention, abstinence, mental health, and employment. Hence, they're often considered motivators for treatment. So, so as somebody who may be working with adults, it may be worthwhile asking for motivators of treatment. And if there are children involved, um, it may help improve their ability to stay in treatment. And then ensuring basic social support, such as safe housing, eliminating exposure to violence, working towards financial stability, can all help alleviate the feelings of guilt and shame. I wanted to just bring up a few different modalities of treatment that are out there. So the first is attachment and biobehavioral catch up. And you can get more details at abcintervention.org. And this intervention is helpful for pretty much from birth up to 2 years. And they work on helping improve maternal attunement towards their infant's cues and helping develop an appropriate response. And they have shown that benefits persist even up to age 5. And benefits are basically as far as, they've also measured things like levels of cortisol in the system and how that the stress system can be reset in the children. Mothering Inside Out is a relatively new form of therapy that is developed by Nancy Suchman at Yale. And the goal is to help improve the parental reflective functioning. um, Basically what they attempt is to help the parent identify and name distressing feelings within themselves, and also then by extension um, come up with reflections for the baby's behavior, so that if a baby is crying, um, kind of stop and try to come up with different possibilities as to why the baby is upset. And they have found that, and this is specifically been developed in mothers with substance use disorders. And they have found a decrease or increased retention in treatment for substance use as well as improved parenting. Child parent psychotherapy is an intervention that was developed by Alicia Lieberman at UCSF. And this focuses more on the trauma aspect, the mother's or the parents' historical trauma that they themselves might have gone through, and how, and works on um, identifying how past trauma is impacting this current relationship of the parent and child, and help manage those distressing symptoms and um, kind of help move forward. PCIT, or parent child interaction therapy, um, is a modality of treatment we often recommend for kids with ADHD, but it's also helpful in kids with you know, kids whose parents have had, who are struggling with substance use or who are um, abstinent from substance use. And it focuses also on an attachment theory basis. It's for a little older kids, like from 2 to 7, and it helps with uh, it helps parents to get more in tune with their child, and also provides them with tools and techniques to help enforce discipline in a positive way. So if you all have the opportunity to um, learn one of these techniques, or um, work with anybody who does these, I think that would be a great addition to your tools. In the end, I just want to leave you with the thought that, there is no manual that tells us exactly how to work with kids. Uh, but I think the key is that for us is to still constantly show up for them and be there for them. Thank you very much for listening.